This video is sponsored by Clinician, but more on them later on the video. Hi everyone, welcome back to my channel. My name is Osadule. So in this video, I'm going to be talking about obstetrics and my experience, as well as give you guys some tips on how to tackle the rotation much better. So basically it is a 6 weeks rotation and we go there every day. On Monday, I had a call. So basically a call is when you go to hospital from the morning, like from 8 a.m. until 1 a.m. So yeah, we did that. But then I want you guys to be aware that my Monday, my call might not be the day that you have your call. Your days might be shuffled. So on Tuesday, I was post call. So being on post call is when you go to hospital from the morning, and then you give feedback to the doctors that are now coming in that morning on the patients that you guys saw at night, because the other doctors were not there. They knocked off at like 4 p.m. So yeah, post call, you actually at hospital maybe until 12, and then on Wednesdays I had clinic day. So there you go to clinic like the whole day, and then you get to see patients that are coming in for the first time, maybe to check if they're pregnant or they're doing like a follow-up on their pregnancy, to check if everything is going well. And then on Thursday we had theater day. So theater day is when you go to theater the whole day. You do C-sections, you get to scrub in, which is so much fun. I really like that part. And then on Fridays it's a grand round ward. So basically here, that's when we go to the high risk ward to see the patients that are having complications with their pregnancy, and then we get to actually like get to learn. It's a learning experience. The senior doctors will come in and then like take us to each and every patient, and then ask us questions, ask the students as well as the junior doctors. So they'll ask questions like the risk factors of this type of complication. They'll ask about the treatment plan. They'll ask about the clinical signs when you first see the patient, like what they might have, that will give you like an idea if it's this type of complication. So basically that's the week, and then you are expected to do 7 calls, 5 weekday calls, and then 2 weekend calls. So usually they want you to do the call on a Saturday, but then if you have like religious things that you have to do on a Saturday, then you might do it on a Sunday. And I would like you guys to choose to do it earlier on the block, not towards the end, because towards the end there are a lot of lot of activities and you can't be on call. You'll be tired, you have to be studying, because on the 6th week, that's where we have our examinations. So towards the 6th week, you have to be ready to chow calls and do your thing. So basically, yeah. And then I also want to talk about the morning meetings. So every morning we have a meeting. That's when you share the stats of all the patients that came in last night, the patients that delivered, any complications, if maybe there was a stillbirth, if there were twin pregnancies. So that's where you share the type of information. And during that time, it might also be a learning moment. That's why it's important to come to these meetings, because they might teach about a placenta previa or placenta abrupta, and then tell you guys about the signs, tell you guys about the treatment plan, like the complication, because those are like the type of things that happen each and every day in hospital. So you have to make sure that you really understand this type of complications, right? So it's very important to attend those meetings. We have those meetings every day except for weekends. Yeah. And then now I'm going to talk about the expectations of the rotation. So you are expected to clerk a minimum of 30 patients, and you are expected to observe 5 natural deliveries as well as perform 5 natural deliveries. So make sure that you do these like earlier on in the 6 weeks, so that you don't stress about the number of patients that you have to deliver. So if you can, maybe you can choose one day. It's very smart to do this on the day that you are on call. So when you're on call, you can just chill or stay at the labor ward, so that whatever delivery is coming, you'll be seeing that delivery until you get your 5 deliveries, because after that you'll now be comfortable to now deliver your own patients. And the nurses are very strict about this. You can't deliver if you haven't seen 5 patients being delivered already. So try and get that done as soon as possible. And then you're also expected to know the Antenatal Card. So this card is the card that is filled in for the first time when a patient comes in and they've discovered that they are pregnant, and then you now do all the tests. And I'll talk about the Antenatal Card later on in the video and the things that you are expected to know on the card. And you're also expected to fill in the card, know how to fill it in, how to interpret it. And then you're also expected to understand and interpret the CTG. So basically it's like an ECG. If you know an ECG, it's basically an ECG, but for a baby. You get to see the heartbeat of the baby in correlation to the contractions of the mother. So you have to be able to interpret that, and it comes a lot in exams, but also I'm going to elaborate on that later on in the video. And then you are also expected to write a report on a patient, and this report is called the case commentary. And this it takes a huge bulk of the mark that you need in order to exempt for writing the exam at the end of the year. So basically, in order to exempt, so exemption means you write the exam now, like after the block, maybe after 12 weeks of doing the obstetrics rotation. And then if you get above 70% for your MCQ together with your case commentary, you're not expected to write the exam at the end of the year. So this case commentary is very important so that you don't get to write at the end of the year, and it carries like 20% of your 100%, right? So you're expected to write this, and I believe you have to submit it on week 5. And guys, make sure that you get your patient as soon as possible, so that at least you have like 5 weeks to write this thing. So yeah, and also I'm going to talk more about it later on in the video. And one more thing, you're expected to know how to discharge a patient. So yeah, this is very important, because also you're going to have a short test. You have to discharge a patient within 20 minutes. And on the card, on the white card that the patient carries, I think there is a discharge form, so you can look at that form and get familiar with that form. Thing is, I've forgotten what page it is, but it's towards the back of the book of the patient. So yeah, just try and see what is expected from you, what things you have to write, because when you're doing your discharge summary, it has to be your own writing. There's no filling in the gaps and whatnot. It's things that are coming from your head in the 20 minutes. So get familiar with that as well. And I'm going to also talk about the discharge summary later on the video, to just elaborate on what is expected from you. Okay, so now I'm going to talk about clerking patients. So basically, clerking a patient is actually taking history and doing examination on the patient, and then writing it down on the file of the patient to present to your senior doctor, and on what you think the patient has, and then what is your treatment plan. And then the doctor will add stuff on your sheet or on the file, and then also tell you that it's actually not this, it's actually that. It's like a learning experience, but it's so nice because you get to learn so much. Because then after the first clerking, you'll then see another patient who had a similar thing that your first patient had, and then now at first I thought it was this, but now it's actually that, so now I know how to actually treat this type of patient. That's what I like about ops, because it's like repetition of patients. So when you clerk in SIMJA, there is a clerking sheet. So basically with that one, you just fill in the gaps. It's really easy. It's not really tough. I want to elaborate when there's no clerking sheet, where you have to write your own notes on the patient's file, right? So here you have to write the date, obviously, the time that the patient came in. You have to write the name of the patient if it's a sheet that's not inside the patient's file, because it happens that the patient has so many notes on the file to an extent where there's no space to write on the file. So patient name, date, time. You also have to write the age of the patient. You have to write if the patient is an early booker or a late booker. So here I think it's after 24 weeks. If the patient did not book for clinic before 24 weeks, they are a late booker. So you have to write that they are a late booker. And here it gives like the risk of the patient transmitting HIV to the baby if they're not taking their HIV treatment, as well as syphilis to the baby. So this patient is more like a high risk type of patient. You also have to write where the patient booked. So here it's like the clinic name, so the clinic that the patient was going to during their pregnancy. You also have to talk about the 4 normal booking bloods, which is HIV, you have to specify if the patient is HIV positive or not. And also if they are positive, you have to say the viral load as well as the CD4 count. And if you don't have those readings, you have to take blood and then send them to the lab so that you'll be able to determine the viral load as well as the CD4 count before the baby is delivered, so that we know is there high risk of HIV transmission or not. You have to check for syphilis, and this is RPR. You check for syphilis with the normal booking bloods, and if the patient does not have syphilis or reading on the antenatal card or any of these normal bookings on the antenatal card, you have to check for them right now while they are in labor. And then for syphilis, when you're doing bloods, it is the TPHA. I think it's TPHA. And then there's also the rhesus positive or rhesus negative. And if the mother is rhesus negative, it's a huge risk because there might be a hydrocephalus, there might be a lot of other complications, the baby might even die. So make sure that you know these bloods. And then the last one is hemoglobin. So you have to check Uguti is the hemoglobin 11, greater than 11, because if it's less than 11, then it means the mother is anemic. And with anemia, there are also a lot of other complications. One of the complications is postpartum hemorrhage. So you have to know about these normal booking bloods, because with anemia, you have to know if you have to transfuse or not. So make sure you know these normal booking bloods. And you also have to specify when was the test of these bloods done, because if it's a test that was done 6 months ago, we might have to repeat it again now so that we know where we stand right now. But if it's a test that was done maybe 2 weeks ago when the patient went for their follow-up, then we know it's okay, so it's around this figures, if that makes sense. So, and then you also have to write about the gestational age of the patient, so the number of weeks that they're pregnant for, as well as the estimated dates of delivery. You also now have to write about the history. So here there's medical, surgical, as well as obstetric history. So with medical history, you write about everything that is not really related to the pregnancy, because with the pregnancies or previous pregnancies, that's where you write it on obstetric history. So here you can talk about if the patient is HIV positive, you write RBD positive, you write when they were diagnosed, that the year, as well as if they are on treatment. And then maybe if they have arthritis, for example, you write arthritis, when they were diagnosed, and then if they are on treatment for that. And then now we move on to surgical history. So here you talk about all the surgeries that the patient might have had previously. You write the year, you write what was the type of surgery that they had, as well as if there were any complications to the surgery. And you can also write about C-sections in this part, because it is a type of surgery, even though you're still going to write it again in obstetric history. So in obstetric history, you write about all the pregnancies that the mother has had before, whether it's a miscarriage or a stillbirth. It doesn't have to be only the alive babies at the moment. So for the first pregnancy, you write the year or the mother was pregnant, and then you write the baby was given in which, the baby was delivered in which trimester. Was it the first, third, or second trimester? You can even write it in weeks. If the mother gave birth in 37 weeks, you'll say 37/40. And then you write if it was a C-section or if it was a natural birth, and then you also write if there were complications or not. So for all the pregnancies that the mother has had, write all that I've just said. Year, the term that the baby was delivered in, the mode of delivery, as well as if there were complications or not. And then now we go to allergies. So here it's very, very important, because if the patient is allergic to a penicillin and there's now a complication, they now have to go to theater. We have to know that we can't give this mother this type of drug, because there might be complications already with what's actually happening with the pregnancy, if that makes sense. And then after that, you write about treatment. So here you write about all the treatments that the mother is currently taking. If they are HIV positive, you talk about the pills that they are taking. Maybe if it's LTD, you write LTD, and if it's TEE, you write TEE. But you have to specify which treatment they are taking so that we don't have drug interactions, right? And then you also have to write about the pregnancy supplements that the mother is taking. You write it down. You also have to ask the mother about other treatments that they are taking, maybe over the counter treatment, or if they are like traditional treatments, if they're like traditional treatments that they are taking. I know a lot of mothers will take islambezo, but I know some of you don't know this, but it's a homemade type of remedy, or homemade type of medication to ease the pregnancy. So you have to also ask about all of those type of things so that you expect what's going to happen during the delivery. And then moving on from history, from the general history, basically, you now have to ask about why the mother's here at the moment. Usually they'll tell you that they're having lower abdominal pain that radiates to the back, and now you know it's okay, they might be in labor. And then if you check the urine, you have to check the urine actually. So when you check the urine and you see that there are proteins in the urine, you'll then now know it's okay, it might be a UTI. You get what I'm saying? So basically you ask them why you're here. My mothers will tell you, I'm bleeding. And now you have to like quantify the bleeding. When did it start? Even with the lower abdominal pain, you have to ask, when did it start? And then they'll tell you, this morning. You write today's date if it's this morning, and then what time this morning. Maybe it was 7 a.m. You write 7 a.m. You say it radiates to the back. And then now you have to ask about if they're bleeding. When did the bleeding start? You ask about contractions. So with contractions, you ask, does it come frequently? And every time when it comes, it is with increasing intensity. Now that's how you know it's a contraction. But if it's not with increasing intensity, not really, So yeah, don't forget to ask about the time. When did it start? And then you also have to ask about if there's mucus with blood coming out, so that's sure. And then you ask about when did it start coming out. You also have to ask about the water rupture. So this is spontaneous rupture of membranes. You also have to ask about that. Ask about the time. When did it start? So basically in obstetrics, it's very important to ask about the date and the time so that you know when can we expect this baby to come, right? So you move on from there. You now do your vitals, check your BP, check your pulse. You have to check your reflexes. You have to check your urine. I've talked about urine already, because here, if the patient has UTI, there should also be leukocytes if there's any other infection and whatnot, which will then make the baby to be at risk. So it's basically to just check where are we with this pregnancy. Are there going to be any complications, right? So this is you writing all of these things down, right, on the file. And then you now do your general examination. You do your anemia, you check your conjunctiva, you check your tongue, your frenulum, you check your capillary refill. Capillary refill, it has to be less than 2 seconds. And then from there, you do your CVS. You're checking all your your valves and whatnot. And then you should have a normal S1, normal S2. There should be no murmur. You're right, there's no murmur. Normal S1, normal S2, right? Move on. You go to respiratory history. You check for breath sounds. Don't forget to also check at the back, and the patient should be seated when you do all of this checking. And then you write normal breath sounds or resonant breath sounds bilaterally, right? You do your reflexes. You know your reflexes most. You know them. You do them here, biceps, triceps. You know them. You did this in 4th year. So yeah, you do your reflexes, and then they should be normal. And a normal reflex is a 2 out of 4. And then there should be no clonus. So you write no clonus, no brisk reflexes. Good. You move on. You now check. You now do your lower. You do your leg examination. If there's any swelling, you do your press to check for pitting edema. If there is pitting edema, you grade the edema, and then you write if there's no edema, negative pedal edema. Yeah, basically that's how you do it. And then now you go to your focused abdominal examination. So with your focused abdominal examination, you first do your inspection, and then you do your palpations, when you're palpating, you're doing the Lippert's maneuvers. You do your fundal grip, your Paulics, your lateral, your deep, and then it's very important to master these examinations, the Lippert's maneuvers, because in an exam you expected to know how to do it, and then if you're doing it right, you will be able to locate the heart of the baby, because you have to listen to the heart of the baby using your stethoscope, and you listen at the back of the baby. But if you can't do them, then you won't know where the back of the baby is. And when you're listening, and you might pretend on the exam that I can hear it, and then the doctor will ask you, Utai, show me where you heard it, and then they listen and they're like, it's not here. So guys, make sure that you master this. And then basically it's inspection, Lippert's maneuvers. So with Lippert's maneuvers, you also know the lie. With the baby's lying, which direction? Is it oblique? Is it transverse? Is it longitudinal? The presenting part, is it is it cephalic? Is it a breech? And then you also get to know, you also do your FSH. So here you are measuring the length of the abdomen, and then it should be correlating to the gestational age of the baby, plus minus 2. So after you've done that, you now have to estimate the baby's the fetus weight. So with this one, you take the FSH minus 5, and it should give you the estimated weight. So here it's to check if the baby is a big baby, which is microsomia, if the baby is growth retarded, those type of things, to know the type of plan that we have to do. Should we now do a C-section, or a normal delivery is still fine? So after that, you also check your liquor volume, as well as, I don't know, what am I forgetting? Let me just also check real quick. And then you also do your head above boom. So you also do this during your deep palpation in your Lippert's maneuvers, right? So you have to know how far the baby's head has descended into the mother's pelvis, because now you know it's okay, so we're about to deliver, or is the baby still a 5 out of 5? And you also have to be able to, I talked about the fetal heart rate, how you listen to it, and then we also have to know uterine contractions, how to palpate for uterine contractions, because I had this misconception that you have to see them on the CTG. In 10 minutes there are 3 of them, and if it's a long graph, then it means they're strong, but you can't really see them on the CTG and then say they're strong or not. You have to palpate for them. So whenever the mother is feeling pain and they are like moving around, that's where you touch the mother's belly, and then you'll see the part that is really strong. You touch on it, you calculate, you put on a timer to see how long they last, because after maybe 10 minutes, then the mother will feel less pain and won't feel pain again, and then maybe after some 2 minutes it starts to happen again. So that's how you know in 10 minutes she has 2 contractions or she has 3 contractions. And then as the pregnancy progresses, as the baby's head is descending more and more, and as in the PV exam she's getting more and more centimeters, the contractions become increasing in frequency and increasing intensity, like how I told you guys earlier on. So those are the 10 things that you have to know with the abdominal examination. So that is your clerking examination, and you're writing all those things down, right? And then you now have to do your PV exam. So PV exam, you check for the dilation of the cervix. So it's important to know what your fingers are what centimeters. I know this is 1 centimeter for me, this is 2 centimeters, this is 3, this is 4, like that, and that's my 10. So you guys also have to know what your fingers are what centimeters, because you don't have the same fingers and the same size fingers. So you check that, you check effacement, and then that effacement is the length of the cervix, and then you write it down. You observe, obviously, the area. I can't say it because I'm on YouTube, but you observe the area, and then you write if there are genital warts, you write if there are any lacerations. So and then you also check if it is a a vertex presentation, you check for molding, you check for caputs. So molding is this, and then caput is the fluid of the head. So molding is when the baby's head bones like become like this, and then you can grade it. So basically it's that. And then yeah, I believe that's it. If there's something I forgot, I'll just add it right here. And then after that, you then you've done the urine, you comment on the urine, the proteins, the leukocytes, and the ketones, and then you do the ultrasound. So usually ultrasound you're not really allowed to do it, but I was so fortunate that when I went to Betha, there was this other doctor. She's so nice, guys. She taught me how to do it, and now I'm able to do the ultrasound. But if you can find a doctor who's willing to help you, and then now you know how to interpret the ultrasound, because you have to also write on the estimated date of delivery from the ultrasound, especially if it's an early ultrasound, so before 24 weeks. It's kind of accurate during that time. So you write the estimated fetal weight, you write about the estimated date of delivery, you write about the head size, the abdominal size, the femur size, and all of those type of things, right? And then moving on from the ultrasound, you now have to write your problem list based on the patient that you're having. So maybe the patient is a first-time mother, you write primi gravida. So with primi gravidas, usually the delivery takes much longer to progress if it's a natural delivery, because they're scared, their muscles are still really strong, they've never done this before, and they might even have to do like an episiotomy, which is cutting on the side so that the baby, it's easier to deliver the baby. So it's a problem list. That's one. If the mother is HIV positive, you write that. It's a problem list because they might be parent to mother to child transmission. If they are syphilis positive, you also write that. If they are rhesus negative, you also write that, because there will be like antibodies interaction, and there might be a hydrop fetalis, there are those type of complications. So make sure that whatever complication you see, you write it down. If they're having a placenta that is located, when you did your ultrasound, if the placenta is located, it's covering the cervix, that's a placenta previa, you write that down, placenta previa. If they are in the latent state of delivery and they are having abdominal pain, you write latent state of delivery. And then now you write your management. What could you give the patient? Do you give a Ringer's lactate? Do you do a APG or a VPG? So here you're checking like for hemoglobin. I know where I was, the hospital, they didn't have the rapid hemoglobin test. So we will have to do a VPG to check for hemoglobin. If the mother had a low hemoglobin during their pregnancy, so we want to know where are they at the moment? Should we transfuse blood before the delivery? So you write that down. You write about the type of interventions you're going to do. Maybe you're going to take blood. If the mother is HIV positive, you have to check for viral load, you have to check for CD4 count to make sure that you minimize the risk of delivery of the virus. So whatever, you have to now give the mother medication to further reduce the viral load. So that's why it's important. So you write all the bloods that you want to take. But if the mother is pre-eclamptic, you're not going to check for the liver function test. You're going to do your FBC, including my platelets, those type of interventions. What else? If they haven't done an ultrasound, you write ultrasound. So that's your management, everything that the mother has to do before they deliver, to check, do we have a problem with this? Do we have a problem with that? To fill in the gaps so that we are better prepared when the baby is about to come. So basically that is the clogging. And yeah, as I said earlier, you have to make sure that you clog a minimum of 30 patients before you submit your logbook. Your logbook you submitted on the last day of your day in hospital. So make sure that you clog as many patients at the beginning, so that what's week 3, week 4, you now have time to just study. And then maybe you just clock 2 patients a day, and then now you're just adding more spaces. I'll show you my logbook. I was adding more lines because now I was done with all my patients, because I wanted more time to study, So make sure you complete your logbook as quick as much like quicker as you possibly can, so that you study. And clerking as many patients as you possibly can makes you better prepared for your ward-based assessments. So basically, ward-based assessment is taking history, doing the examination. Only you now have limited time, and you get to present to a doctor for marks. Obviously, every time when you clerk, you present to a senior doctor, because you're not a doctor. Obviously, you don't know everything. You don't know stuff. You need a senior person to validate whatever you've written. But for the WBAs, it's for marks, and there's less time, because with clerking other patients, you may take the whole hour, but with the WBAs, you only have 20 minutes to clerk and then 20 minutes to present. And then the doctor will have questions about risk factors, about this, about that. You have to be like competent and know your stuff like that. And then it also prepares you for the long case. And the long case carries like a lot of marks. I think it's 20% of the clinical component, while the WBAs is like 10% of the clinical component. So make sure that you clerk a lot of patients and you are comfortable. You know your Lipid's maneuvers. You know where the baby's heartbeat will be, because you found the back of the baby. Just make sure you practice as much as you can. And then also, clerking makes your senior doctors to see you more frequently, and you get to understand stuff, because after you've clerked, as I said, you present. When you present, they'll tell you the right things that you did, the wrong things that you did. They'll tell you the management, and you get to know these things. Even though you were to write an exam, even without studying, you know how to manage the type of patient. And with that, now that you have that knowledge, in the mornings, as I said, in the mornings we have the meetings, but after the meeting we then go for rounds. So ward rounds is when we're going to the high risk patient, and we get to see what this patient had, the patient that came the previous night. So if you clerk the patient and the patient had the disease that the patient that is at high risk has, and then the doctor's now asking questions, the senior doctor's asking questions, you look good, because now you know your answers. They might point you, you answer, and then now you are on the beat, so it's very important to know your staff, because that's where your ward marks come from. It's your senior doctors marking you based on how you do on rounds, based on how many patients you clerk, based on how you understand clerking, and based on your work, if everything is in systematic order. And then when we're going for rounds, if you actually answer questions and you know what's going on. So that's it on clerking. Really like this. Can you see? What's up, babe? Then this card. This is so beautiful. So I'm gonna grab.
Smart.
Pink top. This one's my favorite one. This one is going to be the sun today. I was wondering if things will be on the print. Look at the print. I really like this. And then what I also like, come see, this thing. There's a one that I saw. Which one is it? Come see this. It's clinician, and then it's clinician like that. And I like this as well. This, it's so beautiful. This and this and that. So but I want you to see this, and then make sure that you see or you check clinician scrubs on Instagram. Okay, there you go. Okay, thank you so much for it. And I like this. Come read this. So it's saying, thank you for your order. you have a great taste. That's me, that's talking about me. And then your order made my day. I hope that the scraps makes yours. I would love it if you could share a snap or social media hashtag clinician scrubs, hashtag clinician flex. I think everyone who orders is going to get this card. And make sure that once you've ordered, take a picture and then share it on your Instagram and tag them like how they say here. So yeah, I'm so excited. I'll wear these scrubs today and then I'll show you guys how they look. Okay. Clinician is a proudly South African local provider, manufacturer and supplier of medical scrubs for all healthcare workers and students. They deliver in all provinces in South Africa. They provide custom embroidery as well as different colors to choose from. These specific scrubs I'm wearing right now are of great quality. They stretch, they have side pockets, and the material is thick and doesn't lose color. I really like the highlighting pink cotton around my pockets. It's so beautiful and has that defining factor. So if you are interested, follow them on Instagram at clinician_scrubs and place your order today. You won't regret it. So now I'm going to talk about the deliveries. So most of your deliveries, you're going to get to do them in your peripheral hospital because most of the hospitals that we usually go to are tertiary hospitals, and the deliveries that come there are usually like complications, and you get to have the patient having a C-section rather than having a natural delivery. So there's this program that they've started like implementing, where the students go to unusual hospitals, the hospitals that are like primary hospitals. I remember I went to Betakoa, and then some of my friends went to Tele, yes, and then I forgot the other names of the other hospitals, but there you get to see so many deliveries, natural deliveries, because it's a primary hospital, and whatever complication the patient might be having in that primary hospital, they send them to Bara or they send them to Simja, which is where we spend majority of our rotation, and that's why we don't really get to experience a lot of natural deliveries, because those patients come in for C-sections. So yeah, when you go to the peripheral hospital, you might go in the first week of your rotation or on the third week or whatever week. So don't get anxious when some of the students already have their 10 deliveries, because I was that student, because I went first for the peripheral hospital, and when I came back, all of my deliveries were completed in the second week. So yeah, once you get to go to the peripheral, you'll then complete all your deliveries, so don't stress out about that. And then on the day when you are on call, when you are at Simja or Bara or wherever you might be, make sure that you spend majority of your time, if possible, at the labor ward, so that whatever delivery that comes in, the natural delivery, you get to see all of those deliveries, right? I think I've mentioned that earlier on, so that you'll be able to get your minimum of 5 observations, because the nurses are very strict when it comes to performing the delivery if you haven't done your 5 observations. So make sure that you use those times when you are on call very profitably. And one last thing that I want to talk about based on deliveries is to protect yourself. Guys, this is very, very crucial. A lot of healthcare workers have gotten diseases because they were unable to protect themselves. It might be a needle stick injury, it might be blood when the patient is delivering. Maybe it gets into your shoes, or it gets into your hands, or maybe you are too excited, you want to hold the baby when the baby is coming in, but you're not wearing gloves. So make sure you wear gloves, you wear an apron, and you wear boots, gum boots, whenever you're doing deliveries, whether you're going for a C-section, whether you're doing a natural delivery. Make sure that you protect yourself, because as much as the patient's life is important, your life is also important, because that patient won't have someone assisting them if you're not there to actually help them. So make sure that you protect yourself and you healthy and well. So now I'm going to talk about the case commentary. So I think it's ideal that you choose a patient on the first week. Ideally, it should be someone that you actually were involved in their case, so that it's something that you have like heart feeling towards the case commentary. Because my patient, I was involved in the patient. I also discovered that the patient was having postpartum hemorrhage and they were anemic in their pregnancies, which was very interesting for me. I did not really focus on the PPH, rather I took the route of the anemic pregnancy, because anemia also is a risk factor for postpartum hemorrhage. So yeah, try and choose your patient as quickly as possible, so that you have more time to type your case commentary, because it's usually due on the 5th week, I think on a Friday or a Thursday. And if you choose your patient in the first week, you'll have 5 weeks to type your case commentary. And try and make sure that you choose something that's a bit interesting, because having to write about the same topic, that's why mine wasn't based on the PPH per se, but it was based on the anemic pregnancy, which a lot of people believe they don't really understand. How does anemia cause a PPH? Because PPH is the overbleeding after delivery, but then anemia is having less blood. People are like, what's going on? And then nitric oxide was also part of the component. Nitric oxide being produced by the trophoblast or by the placenta, being produced in high doses, and now it's causing uterine atony. It was really interesting. So try and choose something like that a lot of people don't know about, because also it will help you understand that disease much better. Because it's pointless to write about something that you already studied and you know everything about it. At least explore something that's going to help you become a better doctor. You get what I'm saying? And also to give information, maybe even to the other doctors, if your case report is that interesting, they might also say, oh really, I didn't know about this. So try and go for topics like that, because I believe that will give you more marks. You'll stand out better than someone who's writing the same thing. Imagine if it's 10 students writing on the same topic. It gets boring when you're marking and you're like, all of these, just give them 60% or whatever. So make sure that you write to impress the doctor and inform the doctor, and also inform yourself as a future doctor. So yeah, now I want to talk about the format of the case commentary. So this is an example of how I wrote mine. So I first did an introduction of the patient, as well as explain each section, that in this section I'm going to be talking about this. And with the introduction in terms of the patient, explain the demographics of the patient basically, and how they were presenting and whatnot, just like a short summary. And then you now will go on into history. So under history, you'll talk about the patient's details. Guys, don't write bullet points. This is a report. This is not a presentation, it's a report. So write it in a format of how you write an article. I think a lot of people lose marks because they write in bullet points. Don't write in bullet points. Let me repeat this. Don't write in bullet points. Write in a format of a paragraph. So here, the patient details, write it in a full paragraph, age, gravidity, parity, all of those things. The patient details most, where they live and whatnot. And then the main complaints of the patient, as well as the risk factors. So it's patient details, main complaints. Number 2 is list my risk factors of the disease that they are currently presenting with. And then number 3 is you have to analyze their antenatal card. So this falls under history. And then in terms of antenatal card, make sure that all the risk factors of what they're currently presenting with, you list it down. All other wrong things, if the patient is a smoker while they're pregnant, make sure that you make the marker aware of all of these things. And then you also have to insert the antenatal card of the patient. And obviously, before you take pictures of the file, you have to talk to the patient, ask for consent. May I please take pictures of your file? Also, you have to write that on your introduction that you did actually ask for consent from the patient, and make sure that you also specify, I was asking for these pictures as like to actually use them on a student presentation or a student case commentary. Basically, you use your own words, but you have to explain what it's not for use for something else. It's specifically for school. That's what you tell the patient, and that's what you write on your introduction. So under history, it's those three things. And then under examination, you do general exam. This includes CVS, RESP. It includes all the other like history, examinations. You do your catch cold, your jaundice, anemia, cyanosis, clubbing, edema, lymphadenopathy, dehydration. You write about all those things right here. And then 2, you do your abdominal examination. And then with abdominal examination, I want you guys to focus on the 10 things. So I'm going to list them down right now. It's inspection of the abdomen, the linea nigra, stria, any scars. Don't forget to check for previous cesarean scars. And then you do your FSH, so the measuring of FSH, measuring of the abdomen. 3, you do the lie, longitudinal lie, oblique, transverse. That's 3. 4, you check for the back of the baby so that you'll be able to listen to the fetal heart rates. 5, you check your presentation. So here you're using your Lippitt's maneuvers that I spoke about earlier on. So you check for presentation. Is it a bridge? Is it a cephalic presentation? 6, it's head above room. That's where you do your deep palpations, right? 7, you listen to the fetal heart rate. 8, you check the liquor volume. And then 9, you do your uterine contractions. I explained how you do your uterine contractions. You palpate them. You don't look at them from the CTG, right? And then 10, you write about the estimated fetal weight. The estimated fetal weight, I did explain that it is FSH minus 5 equals to, if the FSH is 35 centimeters, you'll say minus 5. And then 5 is, if minus 5, the answer is 30. So the estimated fetal weight, you add 2 zeros after you've minused the 5. So 35 minus 5 equals to 30. Estimated fetal weight is 3,000 grams, right? Cool. And this method only works if the mother is, or if the fetus is 35 weeks, yes, of gestational age. So cool. And then after abdominal examination, you do your systemic systems review examination. Okay, so at first the general examination is your catch cold, and then your systems review examination is your CVS, your RESP, all of those other systems, MSK, you get what I'm saying, guys. And then now you're going to do your PV exam, and I did explain the PV exam. You PV, check the centimeters, the dilation, you check the length of the cervix, you do the inspection of the area, and then you check your molding, your caput. You also check the presenting part. Is it vertex? Is it brow? What else? I'm not sure if I'm forgetting something. And then now you do your problem list. You do your assessment first. So assessment is actually explaining like the summary of what the patient might be having and whatnot. And then the next one is problem list. You say all the risk factors of like having an abnormal delivery, or the risk factors, because the patient has already delivered. That's why you're writing about the patient. So whatever problems the patient was having, or what let me just rephrase that. Whatever might be the cause of the complication that the patient was having. Maybe your problem list could have been microsomia, which is a big baby. Hence, there was CPD, which is cephalopelvic disproportion, right? And then what else? Shoulder dystocia, same reason, big baby. Those type of things. So here you write about the problems, and as well as like latent phase of delivery, a prolonged latent phase of delivery could be one of your problem list, which then would give a prolonged a second stage of delivery. If it's prolonged, the baby might be suffocating. You now have to do a C-section. So basically, you get what I'm saying? Whatever complication that happened at the end, what was the cause of that complication? So that's what you write on your risk factor, on your problem list. And then you move on to item 6. So item 1 is history, item 2 examination, item 3 assessment, 4 problem list, 5 is partogram analysis. So with the partogram, please be familiar with plotting on your partogram. This is very important because it becomes easier for you to interpret it if you are given in an exam, because now you know, what does this mean, what does that mean. And yeah, here you'll be asked to interpret. There are risk factors on the partogram, so you talk about that, the risk factors, you talk about your plots, you talk about the heart rate of the baby, was it increasing, was it decreasing, you talk about their decelerations, were they absent, were they early, were they late, all of those things, whatever you see on the partogram. But what they really want to know about is the plots, the heart rate of the baby, the liquor, the presenting part, the decelerations, the head above boom, the maternal vital signs. Talk about if the mother was given oxytocin, maybe to easier to quickly progress the delivery. All of those things, you write them down as part of plot 1. Write plot 2, everything. Plot 3, everything like that. Cool. And then now item 5 is discussion. So basically with discussion, this is where you read your articles to find out, like, in the broader spectrum, what is the cause of what the patient was having, what is the percentages of having that type of complication in South Africa, in the world, how is it usually treated in terms of the protocol book. And by the way, guys, there's the protocol book. I didn't talk about that. The protocol book is your bread and butter. You have to know it, like really know it, but they're going to give it to you as a soft copy. So you, in the discussion, you will talk about what is written on your protocol book as well, what's written in your protocol book in comparison to what was done to your patient. The patient was given this, but in the protocol book they say we should give this. The patient was given this, which is the same as what the literature also says, but maybe the patient was given a different dose than what is recommended in the protocol book. So you talk about that, and then you talk about why you think the patient was given a different dose, if the patient was given a different medication. You talk about all of those things, right? And you talk about the articles as well. So it's a combination of everything based on what the patient was having. And then you talk about the critical analysis on your patient. Everything that you think was wrong, or maybe that was incorrectly done, maybe by the doctors, you then say, Guti, you don't think that was done in the right way, maybe they should have done this instead of that. You add those type of things. They should have done this, they should have done something different. Okay. And then you have your conclusion. So with conclusion, you talk about how you feel about the case, as well as what type of experience it was for you. This is why it's important to choose a patient that you were involved in, because now you get to talk about how you feel and how what you learned, and you know, even in your discussion you also talk about that, because now you were there, you saw everything, and yeah, it's a vibe, man. It's nice. You're connected to the case rather than choosing someone random in the ward and then just writing about that person, you know. And then yeah, you choose, and then the last part is your references. References, make sure that you write them in a right way. I don't really remember what's the name called, but you write the surname, you write the initials, and then you write for everyone. You also cite, by the way, guys, don't forget to cite. Whatever you say, you cite using the references every time. So you write on the references, you write the surname, you write the initials, and then after that you write the name of the article, you write the name of the what you call the journal that you were using. You also write the dates that article was published. You then write the page numbers that you were referencing. So basically it's that. And then at the end of everything, you're then going to submit the case commentary to turn it in, to check if you did not copy anyone's work. So if as I have submitted my case commentary, and then maybe for example you got my case commentary and maybe from the drives or wherever, maybe I uploaded it to give you guys an example, and then you take maybe a paragraph of what I wrote and then you also put it as it is, it will increase your percentage of your plagiarism, because my work has been submitted to turn it in. If they've recorded all the paragraphs, all the sentences that I've written, even though I'm not like a publisher, even though I'm a student, but because I've uploaded it, whatever you're going to take from my article and then you add into your article, it will increase your percentage of plagiarism, which will make your marks to go down. No matter how nice your other paragraphs that you wrote by yourself that you didn't take from anywhere else, they were perfect, but then because you copied some of the things and it increased your percentage, your marks will drop down and you might even fail because of plagiarism. They're very strict in terms of using your own work and not taking other people's work. So that's it on case commentary. Now I'm going to talk about the Antenatal Card. So make sure that you are very familiar with this card because it also comes out in a lot of exams. So make sure that you understand it. So basically this card is a communication between the doctor that has been seeing the patient throughout their pregnancy and you now seeing the patient since they are now in delivery. So you will get to know where you stand in terms of if the patient is HIV positive, how much is the viral load, what is the CD4 count, as well as to know if the patient is rhesus negative, which will put the baby at risk of death even with hemoglobin if the mother is anemic, and if there might be like even postpartum hemorrhage with the mother and other complications, as well as to know if the mother is syphilis positive, which means there's a high risk to transmission of the baby if prostituted or not. So make sure that you are very familiar with the antenatal card and be able to also fill it in, as well as look for any abnormalities on the card, because that's what actually comes out in exams. So you have to identify any risk factors. The risk factors might be HIV, it might be the mother is a smoker, it might be a family history of diabetes, which means there might be a microsomic baby, which is a big baby, and that might cause a slower progression in the second stage of delivery. So make sure that you look for everything that might be a risk factor, as well as look at the readings of the ultrasound, if the baby's weight is correlating with the FSH, which is the measurement of the abdomen. So basically look at all of those things, and yeah man, make sure that you understand the antenatal card. Is very important, because even with the case commentary, you also have to interpret your patient's antenatal card. Okay, now I'm going to talk about the discharge summary. So as I said earlier on, it's going to be part of your assessment, and I think it's worth 5% of your clinical component. So make sure that you know how to discharge your patient. So you can ask any of the interns, because I believe every single day they have to discharge certain patients. So you can ask the patient, the intern that is with you in the ward at the time, and then say, when you're about to discharge a patient, please do please ask me to come with you so that you can teach me how to do it. And then the intern might teach you for 2 patients, and then for the rest of the patients you also do your own patients and then show to the intern, and then the intern will add and remove some of the things that maybe you wrote and correct you and whatnot. You also expected to examine the patient. So basically it's history of the delivery. So now it's not history of the pregnancy. Are you bleeding? Are you what, which is antepartum hemorrhage. But you still ask about bleeding, but are you bleeding after delivery? Are you still bleeding? How much are you bleeding? Here you ask about the pad. How many pads have you worn today? is the pad getting full? And then also you examine the pad, you examine the patient for anemia and those areas that I talked about earlier on. And then you do the MSK, where you check for tenderness as well as softness of the calf muscles to check if maybe there might be a DVT and whatnot. So you do your history of the pregnancy, were there any complications, the mode of delivery, and then ask if they were given any antibiotics, were they transfused blood, all of those type of things. And then you also do the exam. Now you do the full exam, you check the abdomen, you still do the abdominal examination, even though now the mother is no longer pregnant, but now you're trying to check if the fundus of the uterus is well contracted, there's no uterine atony, because with uterine atony they are susceptible to bleeding. So we try to make sure they are not a PPH patient, they are fine. So you do that, you check for the scar. If they did a C-section, is the scar pink, is the scar not getting rotten, is everything nice and smooth and going well? You check all of those things. And if they had an episiotomy, you check also for the wound, if it's pink, if it's healing well, all of those things. And also you do a short examination of the baby, and you do the AFASS score to check if there are any abnormalities of the baby. And if the baby had maybe a club foot or whatnot, you also have to write about that. And if there's anything that I forgot about the discharge summary, I'm going to add it for you guys to know exactly what is expected of you. But basically it's clerking the mother, but post delivery. So basically it's that. But make sure that you ask an intern to teach you how to do it. And yeah, because this is for marks, as I said. And don't forget, in terms of the discharge summary, that at the back of the antenatal book of the mother, the white book, there is a page that gives you the summary of what you have to write about when discharging the patient, because you have to check if the mother had received all the 3 doses of the anti-tetanus toxoid vaccination, as well as check if the baby is going to be breastfed by the mother, if they're going to be breastfed by the mother or going to be breastfed going to be fed by a bottle or formula, sorry. And with that's where the AFASS score comes in. So make sure that you also explore that. And then as well, you have to check if the baby received the two vaccinations, which is the polio, as well as the BCG, which is the TB prevention vaccination. I think that's about it. Okay, now I want to talk about the skills that you have to learn so that you are better equipped after being done with your OBS rotation. So you have to be able to do the PV exam. I told you guys about the fingers, how you have to know what centimeter is which for your fingers specifically. And then 2, you have to be able to observe an ultrasound. And if you were like told to do it yourself, be able to do so because you've observed so many ultrasounds. And then you also have to be able to scrap in for the C-sections, so that you get to be up close, you get to see the skin, you get to see the subcutaneous fat, you get to see the rectus muscles, you get to see everything, you get to see the membranes, you get to see if it's a breech presentation, how is it delivered differently than if it's a cephalic presentation. So yeah, it's very, very important, guys, that you get to learn the skill of assisting in a C-section, because one day you'll be a doctor and you'll be on the other side of the table, you'll be the one doing the C-section. So you have to be able to be familiar of how it's done in the different complications, because with the placenta previa, it's a different insertion. It's not the transverse one, the one that you do in the lower abdomen, the normal one. You don't do that one with the placenta previa. Like how I said, placenta previa is when the placenta is covering the cervix. So with the placenta previa, you do a vertical one, and when you're cutting the uterus, you do a classical insertion. So you have to do so many C-sections that you know this by head, because you've seen it being done, and you're not just reading it through a textbook or you're reading it through a protocol book. And speaking of textbooks, guys, this is the textbook that you have to if you want to buy it, but it's only for 6 weeks, guys. So if you're really interested in ops, you can buy the textbook because you're going to use it later on in, being an intern and also specializing. But I bought the book because I was like, I can't read on a soft copy, and this book is a 2023 book. It was released in 2023. They don't have a soft copy as yet, so yeah, this is the book that you have to buy. Yeah, it's very, very informative. And when I'm talking about the questions that they are setting, I'm going to be referencing on the textbook. Most of the questions that he sets are coming from this book, and I like this book because it's a South African based ops book. So yeah, make sure that you don't just read the textbook, you also go to theater, get to experience and get to see all of these procedures being done. Also know the doses of the medication that you give post C-section. So it is the Panado, which is 1 gram. You give it it's QID, which is like I think 4 times, and then you give it when it's indicated. So when you say indicated, you say PRN. You also give Kefsol. You give 1 gram, as well as Kefsol is given 3 times a day. So it's TDS, and then the mode of giving it is IVI. And then you also give Meloxon, which is for vomiting. You give 10 milligrams. It's given per os, as well as the Panado is given per os as well, which is PO, which means it's orally taken. And then there is a Clexane. Yes, the blood thinner. Clexane is to prevent any clots. So basically you give it 8 hourly. You give, I forgot what you gave, but I'll write it down. And then also you give pethidine. You give 100 milligrams. You give it MI, which is muscularly, and then you give it I think 3 times a day as well. So make sure that you know these doses, because when after you're done with the C-section, the doctor will ask you, okay, now we're done with the C-section, what do you give this patient? And now you have to be like, you have to impress your doctors, guys. Tell them, yeah, I'm going to give this, I'm going to give it in these grams, I'm going to give it in this mode, and I'm going to give it this amount of times a day. So make sure that you know that I'm going to write it down here, or it's already right here, so that you guys don't look like you don't know your work. So I've got you. And then also you have to know how to interpret your CTG. So I've explained what the CTG is previously, earlier on the video. It's basically the heart rate of the baby in comparison to the contractions of the mother. So the heart rate of the baby should range around 110 to 160. So if it's more than that, the baby's freaking out. The baby needs to be taken out right now. It's fetal distress. If it's lower than that, it's also concerning, because there's a bradycardia, and that's not good. The baby should have a range that is 110 to 160. Also, you look at the accelerations and decelerations. So let me just break it down for you. So I have a mnemonic which is called Dr. C. Bravado. So it's DR. So the D is demographics, as well as to define the risk. So with demographics, you talk about you on the CTG, you have to say, I see the patient's name, I see the patient's age, I see the patient the PMI number, so the patient hospital number. You also see that it's this hospital. You see the date it was taken in, you see the time it was taken in, because you have to talk about the CTG that has been taken now, not a CTG that was taken a while ago. It's a CTG that's taken now to show you like the latest updates of how the pregnancy is progressing. So that is demographics. Define the risk. So you have to say, if the mother is having the baby for the first time, it's a primi gravida. If the mother is HIV positive, or if the mother is, I don't know, maybe had a previous microsomia, you talk about those type of things. That is the risk, right? That's the R. And then you have C, talk about contractions. Can you see contractions on the CTG? The contractions are there, right? And then as well, you have to talk about the paper speed. So usually the paper speed is 1 centimeter per minute, right? So you have to say that you can see that. The paper speed is that. And then you have to talk about the bra, which is the BRA, is the baseline. So when you're looking at the waves of the heart rate of the baby, you have to draw a straight line using a ruler, and that line, you have to draw a line where you see like most of the thingy, where most of the lines of the graphs are meeting of the heart rates, where they are at. So they might be at 140, so that is your average heart rate. So that's the baseline. And then after that, you talk about the V. Dr. C. Brava. The V is the variability. So variability, in order for it to be normal, it has to be 5 to 25. So that's where you check the range. The blocks of the CTG going upwards, each block is 5, 5, 5. So if the variability is greater than 5, it means it's greater than one block, which is good. And then on the blocks going on side, those are the seconds. It's 5 second, 5 second, 5 second per block going this way, and then the block going upwards is the variability, right? 5, 5, 5 as well. And then you go on to Dr. C. Brava. The A is accelerations. Are they absent? Are they present? They should be present, but they shouldn't be going greater than 160. So my acceleration, they are telling you that the heartbeat is there and it's changing, but it's still a good heart rate. See, it's not the same, but it's good, it's changing. That's what it means. But if it's just the same, guys, it's bad. It's a very bad CTG. So there should be accelerations present. And an acceleration is 15 seconds away from the baseline. Yeah. I think also going upwards is seconds, and going that way is also seconds. So guys, make sure that you also double check that, right? So it's 15 seconds away from the baseline going upwards. And then the Dr. C. Bravado, the D is decelerations. So with decelerations, they're not really good because they mean that the baby's heart rate is decreasing. And if they are late, so when they are late is when the contraction is like this, the deceleration is this way. So they're coming after a contraction. That's a late deceleration. That's bad because it means the baby is suffocating. There is fetal hypoxia, basically. That's not okay. And that's one of the other indications of having a C-section. Okay, cool. We move on from my deceleration. We now go to the overall. The last O is the overall interpretation overall impression of the CTG. That's where you talk about if the CTG is reassuring, it means it's good, it's a normal CTG, there's no abnormalities. Or it's non-reassuring, you mean like it's something suspicious. Or you say it's a pathological is when you see there's something definitely wrong. The late decelerations and the prolonged decelerations, the one that you usually see on the textbooks, or sinusoidal decelerations. I think that one you see it with the code prolapse. So make sure that you know how to say this CTG is reassuring, not reassuring, pathological. But then I believe as a student we're not allowed to write on the CTG. You can just interpret the CTG to a senior doctor, and then they are going to write everything. How is it the CTG, right? So yeah, that is the skill that you also have to learn. The other skill is the ABG. So this is arterial blood gas or a venous blood gas, which is a VBG. So you have to be familiar with the machine. As a student, this is your purpose. I'll repeat this. This is your purpose. Taking bloods, putting my IV lines, as well as taking the blood and going to get some results from the machine. That's your purpose, especially when you're on call. So make sure that you know how to use the ABG machine, how to put everything in, everything. Just make sure that you know. Also find out about the PIN or the password of the machine, so that you don't run around trying to like ask people, and now it's an emergency, they want to know the readings, like is in like now, and you're still trying to find the password or the PIN. So make sure that you know that like earlier on, so that you don't have any problems. So it's that. Also be able to interpret the ABG. Cool. And then I'm now going to talk about the bread and butter diseases of OBS, basically. So the diseases that you have to know at the back of your hand, like this. So these diseases, you have to know them for the ward rounds. So the ward round is when you, in the morning after the meeting that you have, and then you go into each and every patient at high care. That's where you should know them, because the doctors might ask you questions, and you should be able to know these diseases, because that's how you get your ward marks as well. And then you have to know them for your OSCEs, because in your OSCEs they'll ask you specific things, and you have to know how to write about these type of things, and also know how to what treatment you should give, and how you would even see that it's this instead of being that. And then also on your word-based assessment, which is your WBAs, as well as your long cases. So WBAs, you choose your patient, which patient you would like to do your examination on. So maybe if you are familiar with preeclampsia, you might choose a patient that has preeclampsia, because you know the treatment, you know everything about that patient. But with your long case, it's the same thing as a WBA, the way that they are testing it. But with your long case, you don't know which patient they're going to choose for you. They choose your patient. So if you don't know the disease, and maybe they're giving you a prom, or they're giving you a rupture placenta, and you're not familiar with the treatment and the science, you'll have a problem. So that's why it's important to know the bread and butter diseases of OBS, how to treat it, and all of that. So you have to know how to define that disease. You have to know the clinical signs. You have to know the risk factors of that disease. You also have to know the complications of that disease, as well as the treatment, as well as the investigations that you're going to do in order to confirm that it's that disease for real, right? And then those diseases are preeclampsia, eclampsia, and you find this on your protocol book, as well as the book that I told you guys that you have to buy, or maybe try and find the soft copy, but it's not available as yet. And so it's preeclampsia, eclampsia. It is antepartum hemorrhage. So here you talk about the placental causes of antepartum hemorrhage. So basically, antepartum hemorrhage is when you're bleeding before you give birth, but your pregnancy is a viable pregnancy, so you are more than 26 or 28 weeks of gestation. So there are placental causes of antepartum hemorrhage, as well as non-placental causes. So with placental causes, it is a retroplacenta, it is a placenta previa, it is a vessel previa. And then with non-placental causes, it is a ruptured uterus, it is a cancer, a cervical cancer, it might be lacerations, any reproductive lacerations, it might be an infection of the cervix. So you have to be able to know all of these things and identify which one is it. And then the most common cause of an antepartum hemorrhage is a ruptured uterus. This is an exam question. And then there's also PPH, which is a postpartum hemorrhage. Here you talk about the 4 T's. So there's tone, which is when the patient has uterine atony, the uterus did not contract, and as well as the uterus is inverted. And then the second T is tissue. So here it's retained tissue. Maybe when you were removing the placenta, which is, I think it's the 3rd stage of delivery. Yes, when you were removing the placenta, some of the placenta was left inside, so this will cause bleeding. So it is retained product, so that's tissue, or some clots are still inside. And then the third one is thrombin. So if the patient has any bleeding disorders, or maybe they are experiencing DIC. And then the last one is trauma, maybe if there are any lacerations on the reproductive area. So yeah, those are the 4 T's of postpartum hemorrhage, which like a bread and butter of OBS. And then the other one is chorioamnionitis, the other disease that's very important. Also anemia in pregnancy, I've talked about this earlier on. and a lot of people don't really understand this. That's why I chose it as my case commentary topic. And then bridge presentation, you have to know about code prolapse. Oh my god, they like this exam question. During my OSCE, I had this exam question, so it was the first one. It was say the treatment, and it was 10 marks. So make sure that you guys know about this. And then UTI in pregnancy, I talked about this earlier on, that if the patient has low abdominal pain and they're having proteins as well as leukocytes on their urine, they might be having a UTI. Cool. And then polyhydramnios. With polyhydramnios, you have to know the maternal causes of polyhydramnios as well as the fetal causes of polyhydramnios. With maternal, it's usually diabetes. I forgot the other ones. But then with fetal causes, it's usually a gastric atresia such as esophageal atresia or duodenal atresia. So make sure that you guys Google all these causes. Please do that, because now I'm thinking of them like on top of my head, but I can't remember everything. So make sure that you know these things before your ward rounds and all of that. And then now I'm going to talk about the commonly asked questions in OSCEs. So now, this is the last topic actually. So the question that they love for OSCEs is an umbilical artery Doppler. So they're going to show you an ultrasound. They're showing the arteries. So the arteries, this is the picture of how they will actually show it. So there might be it could be a three-cord vessel. So the three-cord vessel is 2 arteries and a vein. So that's the normal presentation. 2 arteries and a vein. When it's abnormal, it's when there are 2 vessels, right? There's 1 artery and 1 vein. You have to know what might be the complications of the fetus having only 2 vessels instead of 3 vessels, right? So that's an exam question. And the other exam question that is very familiar is the episiotomy. So you have to know the indication of the episiotomy. I think I've also spoken about this earlier on in the video, and which layers are cut whenever doing the episiotomy. The skin, like all the layers, you have to know which one, and you have to know them in order. And then as well as the local anesthesia that is used, as well as the percentage of the local anesthesia. So here it is lidocaine 1%. And then you have to know the different types of forceps. You have to be able to identify the forceps, as well as know the indication of each forceps. So there are the short forceps and then the long forceps. I think for the short ones, it's only the Wrigley's forceps. So yeah, it's the Wrigley's and the Pinja. The Pinja. I'm not sure if I'm saying that one right, but that one is the one that is used for a bridge presentation. So you have to know the forceps, identify them, as well as in their indications, and you have to know when to use forceps, as well as know when to use a vacuum. So know the indications for each and the contraindications for each. You also know the different vacuums. There's the bird, there's the kiwi. The kiwi cup is very, very familiar. They like repeating the question in OSCEs. So make sure that you know the indications of the kiwi, as well as how it looks like. Be able to identify it. Also know PPH and APH. I think I've elaborated on that one, which is antepartum hemorrhage and postpartum hemorrhage. Know that, and know the classification of shock. This is table 27.1 from the textbook. The textbook that I earlier showed you guys, the South African textbook of OBS. So I'll also write the name, the page number of the textbook, because I've forgotten the number, but it is table 27.1. And then also know your code prolapse. I can't emphasize this one enough. They really like this question. And also know HIV in pregnancy, as well as shoulder dystocia and microsomia in general. With shoulder dystocia, you have to know the management. So the management is MAPS, which is Mark Roberts maneuver, and suprapubic pressure, as well as the interior. You take out the interior shoulder and then the posterior shoulder, those type of things. And then there is the swivelers, I can't remember, salvage, yes, it's salvage, where you cut the clavicles of the baby to shorten the shoulders. So know all of that. And then you also have to know the sickle cell disease. There's a difference between homogeneous as well as heterogeneous. So what I've heard is that people who are homogeneous, they are actually protected from having malaria, and then people that are heterogeneous, they are more susceptible to having malaria. I'm not sure if I'm saying that correctly, but if I'm not, I'll correct it, guys. But there's a difference between those two, and you have to know that in terms of malaria. And then you have to know the partogram. They like this question of giving you a cephalopelvic disproportion patient on a CTG. So you have to look at the CTG and able to see this is cephalopelvic disproportion, and then you have to say why is it that. So be familiar with the partogram as well as cephalopelvic disproportion. And then you have to be able to calculate your maternal death rates as well as your perinatal don't. So that is the MMR and the PMR calculation. So you have to be able to calculate that. First, write the formula correctly, insert, which is substitution. We learned that in maths, and then give the correct answer. You get 3 marks for that, I believe. And then also know diabetes and pregnancy, how to treat the mother, the ranges of the OTT, because you give a different treatment if the mother has glucose that is greater than 11.1. So that's where you give insulin. But if it's between 7.2 to 11.1, you give metformin. So you have to know all these things. You also have to know the predisposing factors of the mother having gestational diabetes. And then you have to know hypertension in pregnancy. So here you have to be able to define hypertension in terms of pregnancy. So hypertension in terms of pregnancy is when you have a systolic blood pressure of greater than 140, a diastolic blood pressure of greater than 90. It's taken between, you take 2 readings 4 to 6 hours apart. So you guys get that. Or it's a single reading of 160 over 110 millimeters mercury. So you have to be able to, define it, but don't define it in terms of the normal hypertension. This is different. Use those figures and the different times. And then there are different types of hypertensions. There's the gestational hypertension. There is chronic kidney disease. There is essential. So chronic kidney disease and essential hypertension, you have those ones before 20 weeks of gestation. So with essential, maybe they had the hypertension before they were even pregnant. And then with chronic, it's when they're also having protein. I believe they're also having proteins in their urine, but it's before 20 weeks of gestation, or they've had a chronic kidney disease even before they were pregnant. So those are the 2 ones. The third one is gestational hypertension. The gestational hypertension, you get it after 20 weeks of gestation. So you see the timeline. You have to differentiate between the timeline after 20 weeks of gestation. But with gestational hypertension, there is no proteinuria. You guys understand? And then the other type is preeclampsia. So with preeclampsia, it's also after 20 weeks of gestation, but here you also have proteinuria, or you're also having a organ dysfunction. So organ dysfunction being HELLP syndrome, maybe you're having a liver disease. And then the other type is superimposed preeclampsia. So with superimposed preeclampsia, it's when a patient who had a chronic hypertension is now developing a preeclampsia. So the patient came in, they already have a hypertension even before they were pregnant, but now they're having proteinuria, or now they're having organ dysfunction. You guys get it? So they like those questions. And then now you also have to know about the presenting part of the fetus. the longitudinal lie, the attitude, all of those type of things, head above broom, all of that. So make sure that you are very familiar with these questions, and also look at the advice document. Guys, I can't emphasize this enough. Look at the advice document that is given to you by the students that are from the previous years. Also ask other students that have already done the rotation to try and find out information from them. How was the rotation? Any tips? Maybe what type of questions came in for them? So that you know what is expected from you. You know, with this degree, you can't do it by yourself. You need a team so that you'll be able to do well. You can't isolate yourself. It's a multidisciplinary team effort. Even when you get to be a doctor, you can't treat a patient by yourself. You need a nurse, you need a psychologist, you need an occupational therapist, you need a social worker. You need so many people to help your patient. So treat your medical degree like how you would treat when you become a doctor. You also need other people so that you will be able to succeed. So make sure that you don't isolate yourself. And yeah, that's the end of the video, guys. Thank you so much for watching, and thank you so much for subscribing. I'm seeing a lot of new subscribers. I really appreciate you guys subscribing to my channel. I really appreciate you guys, and I love you guys. So yeah, I'm wishing you guys all the best with your rotations, and I'm going to be doing more and more videos that are rotation based, giving you guys advices like this for each and every rotation. So I hope you guys enjoy these type of videos. So yeah, I will see you guys. Bye.
Our greatest glory is never in falling, but in rising every time we fall. If you liked this video, please give it a thumbs up and subscribe to this channel to get more videos like these. Thank you to the new subscribers, very much appreciated.